Okay, so now we've done a lot of listening. It's time to get a little bit more interactive. We're going to do that with a Translating Research into Practice panel discussion. So go ahead and bring the chairs out, and I will, at the same time, introduce the facilitator of the panel, Dr. Morag Taylor. Morag is a senior postdoctoral research fellow at Neuroscience Research Australia with an NHMRC ARC Dementia Research Development Fellowship. Currently, her work is focusing on the physical, cognitive and fall injury risk and prevention in older people. You're trying to cut me off.
Wrap it up.
With dementia, in people with dementia. Morag is a physiotherapist with extensive experience in working in aged care rehab as well as the Falls, Balance and Bone Health Clinic at Prince Wales Hospital, was it not?
Yep.
Okay, thank you, Morag. You're going to take over from here for about a 25-minute discussion with a panel and then Q&A with the audience. So get your questions ready.
We need 6 chairs, yeah? So I'll get our panel members to join us. So I'm not going to go through everyone's bio who we've already heard from this morning. So Lorraine, our Lifetime Achievement Award winner, if you could please join us. Professor Stephen Lord, Professor Kim Delbaere, and I will introduce our other panel members who are also, I noticed, all speaking this afternoon. So we've got Dr. Jennie Hewitt, who's a physiotherapist, educator and academic researcher with a passion for delivering best practice. She's won a bunch of awards, but you'll probably mostly know her for the Sunbeam program, which successfully prevented falls in residential aged care. So can you just wave, Jennie, so people know who you are? We've got Deborah Moore. So Deborah is a registered fitness professional. She's worked in public health and the fitness industry, and she's project manager or project lead for the Active Stronger Better pilot project, which is in the Hunter. Mm-hmm. Yep. And we've got Amanda Bates, who, do you want to wave, Deborah, so I can? Yep. Amanda Bates, who works in health promotion for the Illawarra Shoalhaven Local Health District. She's trained in exercise science, nutrition, dietetics and public health, and she's currently undertaking her PhD at the University of Sydney. You can see them all up there, that's good. I should have known I made the slides. So this session we're just going to talk, we've got a few different things, but we'll focus a little bit on the call to action. We will invite you to ask some questions, but I will also put some things to the panel. So I'm not going to go through all of these because you saw them in Kim's presentation, but we're going to start with talking about translating research into translational research or implementation research and practice. So Steve, I might ask you, if I can, what is translational research? How does it differ from our other research?
Well, it goes beyond something very controlled. Like a randomised control trial, for example, is kind of like the best case scenario. It's still hard to do, but that's probably as good as you can get. The next step really is to roll this out in something that represents really quite closely everyday routine practice. So, working with people who are, actually at the coalface and making sure that it is an actual example of what it will be like in the real world. So it's going that next step, co-designed, working with people who are in practice to make sure what we think we found in a trial actually happens when we roll it out.
Okay, and you might be able to touch on this as well. So why is it important over just our normal randomised controlled trials? So we say that the Cochrane, our gold standard evidence is the Cochrane with a bunch of randomised controlled trials summarised. Why is translational research important?
I guess it's the same answer. That's the best case. That's when you can really control things. You've got extra support, extra research support. When it's rolled out, we really need to show that it does work in the real world, and also, of course, you learn a lot in the process of how you might need to adapt it and make sure that it is going to work and that it's meaningful and appropriate.
All right, and I'm going to throw over to Kim now. So Kim has recently had a partnership grant to run an implementation trial looking at implementing Standing Tall, which is a exercise program designed for older people, delivered using digital devices. What can you tell us about what you learnt from doing implementation research over our usual is it effective research?
We learnt a lot, didn't we? Morag was the manager of that trial. But I think something that Steve said is absolutely key, is co-design. Like when we do our research, like with the randomized controlled trials, we do co-design with all the people, with the participants. But one of the key things that I have learned is that we really need to do that same co-design even more rigorously when we are implementing research into practice. We had the additional challenge of floods, bushfires, and COVID pandemic. Didn't help. But at the same time, we also, like for future translational research, it needs to be simple. Like we are asking clinicians to change practice for what is essentially still a research trial. So that means that they have to go through ethical and consenting processes, which they're already not used to, and it's challenging. But if you then add another complex intervention to it, which we can do in research settings, because it's controlled, you train up your team, you get into it and you get it done. But in clinical practice, it's a lot different. And a simple change that will make a lot of difference is what we should be doing, and that's my lesson learned.
Has it changed the way you may do an effectiveness trial, having done the implementation trial?
Yeah, well, I think so, because it is a lot more, what's more important now is like within our effectiveness trials is to find the single most effective element of an intervention so that you can actually simplify it a lot better. Keeping it simple is the key.
Okay, and I'm going to throw to Jennie now. So Jennie ran the Sunbeam trial as part of her PhD, and it successfully prevented falls in residential aged care. And you have been a strong advocate for falls prevention with the Royal Commission, and you've since been rolling out Sunbeam to public health networks and residential aged care facilities. Can you talk about some of the successes and challenges you've had in that process? I don't want to take too much away from your talk this afternoon, but...
That's all right, there's a few talks on, so I'll give you some key points and then you might choose to go to the others if I've answered your question. Yes, so it was fascinating really in December of 2020, near Christmas time. I received a phone call quite late at night to say that in response to the interim report from the Royal Commission, the government was looking for an exercise program with proven efficacy to roll out in all of the aged care facilities that had at least 2 cases of COVID during 2020. And the reason for that is that we weren't yet rolling out the vaccinations. They were still under development. And so if anybody was diagnosed in an aged care home with COVID, the whole home had to sit in their own rooms, pretty much in solitary confinement. And so the flow-on effect from that is that people that were mobile were suddenly not mobile, especially if they'd been sitting in their rooms alone for a long period of time. There was a rapid decline. And so all of a sudden it went from a PhD project to something that was going to be implemented across 11 primary health networks with or without a gym. I had gyms in the Sunbeam program. And they wanted the program on a page and they wanted to start it in the new year, and this was on the 20th of December. So I spent Christmas celebrating with my family and wondering how to make a program on a page. And then we did do that, and that involved listing the exercises as they appeared on, according to the protocol from the Sunbeam trial, and writing it in a way that could be implemented with or without a gym. So using the same key principles of prescription, the same number of sets, the same level of difficulty and so on. And all of that had been based on work that Anne Tiedemann and Cathy Sherrington had published back in 2011. So then there was one webinar and one video, and it was just pretty much sent out to the masses. Have I answered
And
your question?
Challenges you've had along the way?
Well, the challenges are, it was a bit of a cookie cutter approach. We all know that residents have their own goals and their own reasons for wanting to attend. And same for the therapists. So that was OTs, exercise physiologists and physios were asked to implement a program that they hadn't. So there was no co-design in it. I guess that's where I'm going. And so that did provide some challenges. But 2,500 people participated. Another challenge is that it was internally evaluated, and the current report, which did show success in terms of physical performance, that's all they measured, not falls, is sitting with the ministry. And there's been a change of government and it's not publicly released, and I can't say anything else apart from that.
And Deborah, Amanda, do you have anything you'd like to add to the challenges or successes of implementing research into practice?
I guess I'm a little bit of an oddball in this lineup because I don't have a strong academic or research background, but
That doesn't make you an oddball. just to let
you guys
know.
the oddballs.
Steve's the oddball.
Oh, is he? Fair enough. I'm in good company then.
We call it the cuckoo clock.
I guess what I'm taking away from a lot of this stuff and a lot of the listening that I do when I do attend sort of conferences and research presentations and other people that I work with who are in academia and research land is that individual variation and the applied setting and the variations in those. So there is so much stuff that we know that is good and that can be done and has been proven for decades, and yet we still find that kind of it's a difficult thing to implement within a number of different settings. And I think Sally mentioned it in that little video clip earlier that you were showing, Kim, that one of the big reasons why people don't come is out of fear. And I don't know if we've sort of encapsulated just making it welcoming, just making it easy, just making it progressive. We don't have to do this number of reps and this number of sets kind of from day one. We need to kind of gradually bring that into being. And I was teaching a class yesterday and we were in the seats and we had weights, and so we were doing all of the things that we know is good. But when we asked them afterwards why they came, it was because it gave them a plan for a day, because they were going to go for lunch afterwards, they were going to go for a coffee afterwards, they have fun with their friends. They didn't even for a moment think, because it'd be helpful to get up and out of the chair and, be able to step over that particular hazard in my home. So I guess, not that that's necessarily answering that question, but that's where, from me, that's how I translate the research into the bits and pieces that I do.
Yeah, so you've got to find the individual motivators.
We ran a home-based exercise program that was an NHMRC grant, and we had 617 participants, which we recruited from the community, who were all quite highly motivated. They responded to an advertisement in a newspaper or a flyer. And now we've done a small trial of an adapted program for people with COPD. And working with people with chronic conditions, we didn't get anywhere near as many people as we thought we would put their hand up to take part, and those that have taken part have a number of challenges to taking part. So it's a vastly different experience for us, moving to working into a translational real-world setting of people with chronic conditions that make them at higher risk of falls.
I guess one other thing I'll just comment on in terms of the implementation trial that I worked on with Kim was that clinicians like to be able to use something for whoever they think it will benefit. And for the implementation trial, we couldn't do that because it's an ethically approved trial and there's select patients that it's been shown to be efficacious in, and so we had to use the same criteria, and that's annoying. Because people said, oh, well, I would have used it with this person, but you can't because that's not what the study is allowed to do. Yep. So we're going to do a little shift here, and we're going to talk about engaging with government. So, Lorraine, I mean, I guess we can talk about engaging broadly, but engaging with government, can you think of, you don't have to give me 5, but what are some hot tips? That's what I like to ask the people at the restaurant when I'm ordering. Can I have a hot tip, please?
Do you know one of the things that gets people engaged, particularly politicians or CEs, is when a family member has had a fall? So our CE, now the Clinical Excellence Commission is relatively new. He joined us in August, was it, last year? And when he met with us as a team, his first comment was he's just been through a few terrible months with his ageing parents. One fell and the other one fell on top. And both of them ended up in hospital, and one since has now needed to go to residential aged care, which we know is a precipitating reason. And I think he was shocked with the system, the process, what happened in hospital, all sorts of issues that he identified from that respect. I do know that also other politicians more recently have had a fall, and I think it's then that if it's an injury, personal harm, whether it's to them or to a family member, that it has meaning. So I've often found when we start talking with falls, I've had a person I used to report to, and Ingrid would be aware of this, and Marie at the CE, and he said, Lorraine, they're all going to fall, they're all getting old. And he used to laugh at me, and then, and he was a geriatrician, he knew how difficult it was, but he used to just, and I think that's the perception, it's around how do we change the perception? And I think Pam started that process initially by getting the data. And it's what we've done now again. It started through the national call, and what we're trying to do in New South Wales is to highlight the implication of what it is to the system. But it's not only to the system and the burden that we have in healthcare services and delivery. The dollars attached to that and what it means is really important at a high level, to government level. That makes sense to them, where the money's going. But it's also to look at what the personal cost is to individuals and their families, and how we represent that, the trauma, and how we articulate that well. And so I think it is shifting the conversation around falls, because the perception is it's an old thing, an old age thing, and people are clumsy and all those sorts of loss of independence an issue. It's around how we make it an important conversation around the meaning it has for an individual and for us as health service professionals, and the cost of what that is, not only in terms of health expenditure, but at a personal level as well.
And I might just ask you, Deborah, you've had some success in local funding?
So we just nagged a lot. We know that we're on a good thing.
We'll call it persistence.
Oh, okay. We persisted a lot. The Hunter Ageing Alliance represented Dr. John Ward, terrific advocate, and Novacare, a local community aged service provider in Newcastle. We've partnered and went out and visited pretty much every MP, every federal and local opportunity that came about, and basically put forward the idea that exercise for the older adult is a really good thing, and we were able to provide so many reams of papers, and they really couldn't ignore it. So what we were able to do, Brad Hazard's office was able to supply some funding for us to do a little pilot project called Active, Stronger, Better. And essentially what we're trying to do with that project is very much what has been done in the past with programs like Heart Moves, Active Over 50s, where essentially engaging the health professional to refer to this community-based program. All of the programs are low to moderate intensity. They are run by fitness professionals. And I guess that's going back to that research question. I would love to see a little bit of research where the supervisor or the guide within the intervention is a fitness professional. So if you provide some additional training, can you do this at a community-based level out? And we know that we can because we've done it before, but we need to reprove that. And so we were successful by nagging a lot and being very persistent.
Did Did you want to say something, Amanda?
Yeah, I'd like to see something broad, statewide. My kids get 2 $100 vouchers every year to participate in physical activity at the moment, and I'd love to see my 74-year-old mother get the same thing.
And just in the meeting we've had at our round table, we've had discussions around how we can elevate it to that level. So we're not meaning small, we are going tall, and we've actually got our Secretary of the Ministry of Health involved in those discussions. So that is used as an example so far in some of that conversation that we've had.
I think I'll just throw it. Does anybody in the audience have something they would like to ask the panel?
Morag, can I just make a point on that before we go on?
You can. If you have a question or comment, please put your hand up and a microphone will come to you.
I think it's important when dealing with government if we come with solutions, not just the problems. They need to hear how they can do something meaningful while they're in power. And if you can give them a solution that can be achieved while they're still in power, not something that's going to take 10 years and then the next government will take credit for it, that really helps. And we know that falls prevention, you can implement interventions now and make a change within a 12-month period, and that makes them look good, and that helps with the people you're talking to as well.
Any questions from the audience or comments? There's a question on Slido. Is there a strong place for adaptive trials in this field? We'll go to the oddball.
Probably. It's. I must admit, I've not been involved in one. I think I guess it's that idea of co-design and interaction. It hasn't what we've been funded to do so far, but yes, the answer is yes. I'm sure it would be a very complementary, good next step.
And I guess you covered this a little bit, Kim, in what you said. Do we just need to rely on organisations, or should we try and get individuals to chip away?
I think both. Every individual here can do something. And, like what I did as an individual, I went to talk to my local MP and gave him a report that he had to hold awkwardly for the entire time he was at the station. But it was there. And even like I've got a friend who also spoke about this, who's not at all related in falls. So it's not like I talk about falls in my social life all the time. But I do think every individual can make a difference. But as a manager of an organisation, you've got a responsibility. And it's both within your organisation as well as talking to other organisations. We're not competing here. We're working together to stop people from falling.
You go, Deborah.
I was just going to say, not just as a manager, but as a knowledge holder of all of this information and how to put that into practice. And I guess holding that bit of paper with the MP goes exactly to what Lorraine was saying. Jennie too, just if they can do something important while they're in office, and if it's personally relevant to them, and if it's not relevant to them right now, it will be, and it's definitely relevant to their constituents.
I think consumers have a big place to play, a role to play. Bob Barnes, we didn't hear his full story today, but those of you who can access the video from, I think it's on the website, the Australian New Zealand website, the full video, is it? Yeah. I urge you to listen to it, because it's an older person talking from personal experience and what it meant for him. And the way he's translated that is to work with Rotary. So he has a mission as a national agenda around, it started with night lights because his wife did fall at night. They were in a motel and she couldn't wayfind and slipped on a mat, not a rat. And I think from that, the level of it raised with him what could he do. So he works with Bunnings in the sense that he's run trade displays in Bunnings, but he's used resources and talks to people, and he talks to people, and he continues to talk to people, and he's saying, and he's got local members in that Northern New South Wales involved in what he's doing, and they approved some funding to support his campaign around nightlights and fall prevention. So they're the people, I think, that can speak very powerfully, and they can speak very powerfully to their age groups as well.
Okay, and we're coming close to the end of time, but I'm gonna finish with one point. We're not going to do all of these because some of them we've covered in the talks that were just in that session. But can we future-proof ourselves? Kim, you can go first.
Well, we need to stay active. That's what we need to do, and we need to get that message out. It's never too old to exercise, as the last point, and it's definitely something that I feel we need to move away from that stigma of physical activity. Like, exercise is probably not always the right word. Physical activity might be a bit more accepted with the older population, but to keep active, keep moving. And that's what we can all do now. We can future-proof ourselves and set an example for everyone, but just making sure that we advocate on that, both in relation to falls as well as optimal ageing and ageing well.
I think we've got a question from the audience, so we'll just finish with that.
Just a quick question, which may not be a quick answer. We're from inpatient hospital sort of based issues around falls, and a lot of the research obviously is around community based. The problem that we have is the patients come in, they've already fallen. So it feels like the big gap in funding is getting people to exercise before they come to the emergency department. So with something like Fitter, Better, is it Fitter, Better, Stronger?
Active, stronger, better.
Active, Stronger, Better.
Okay, so with that program, sounds like a fantastic program. Is it government funded already, and is it only a local?
The local program is a pilot, and we're hoping that at the end of the pilot, sort of towards the end of this year, we'll be able to, I guess, take those next steps to make it. We would like it to be a government-funded project. We believe that it is the role of the government to have this kind of knowledge based somewhere, who then train people to go into residential aged care, hospital settings, community, anywhere and everywhere where the need is, so long as it's safe and effective. And I guess one of my little ideas would be to have someone in a hospital setting, not necessarily a physio or a nurse or OT or EP, but someone who can just literally take people for a walk, hold on to the rails, do a few squats, those kinds of things that are really, really important from day one of recovery.
I think the thing is that we've got to capture the people that aren't in the hospital, aren't in the registered aged care facility, haven't fallen over yet. So, and I think that gap we don't have in New South Wales Public Health, which is where we're from. How do we fund an exercise group for that? We're talking about a huge resource. It's a whole department that has to be put out through the whole of the state. I mean, it has to be run by physios, OTs, a whole resource of people. But it's a huge gap, and unless we fill that gap, unless the exercise gets done, lower limb strengthening and balance on a wide scale that's funded, so people don't have to pay for it, that's what we need.
I'm going to make a quick comment on that one because I think you're right, but I think it's how we go about it. And we have unfortunately watched from our prevention way, for what we've been doing in New South Wales, a retraction in regards to how we would fund programs to support older people. But we hope through this conversation that we're having now with the National Call for Action that we will see more effort and more commitment. And I do think there's a role for where health and health services role, and we've got physios and OTs and people working in different transition programs and so on already beginning to affect some change and work with people who've had a fall or maybe indeed at risk of a fall. But we also need to work with other agencies because we can't do it all alone. So it's how we work and get that agenda happening in a broader sense, so that we not only see it as it belongs to one person, how we can build on that. And that's what we're about now.
I think there's one more question or comment from the audience. And then we'll
Yes,
finish
talking
up.
again about the broader sense, I feel like the programs and the research you've done have been with volunteers, and they're often people who are happy to be active and do that sort of thing. But it's another whole thing to be able to go to a women's refuge in Surrey Hills or with care facility there and motivate those people, like one of your speakers said with the chronic patients. Have we had much research done on people that weren't volunteers and that haven't exercised their whole life and done that sort of thing? Is there anything in that sort of setting?
Ethically, we can't. In terms of research on people who haven't volunteered.
Right. Do we have to call it research? Can we just do it? Can we just do it before and after?
Health systems can implement whatever programs they want and measure outcomes, but you just can't publish it unless you have ethics. So it's, Steve, you might have another comment.
I think the closest thing that's come to that is like whole population health research. Going back a long time, there was a project up in the north coast of New South Wales that put in lots of sort of I guess it was health promotion, and looked at the fall rates in the whole area compared to a comparative area in Queensland, for example, and that was beneficial. But we're stuck, of course, with informed consent, so we need to have volunteers, and it's a big bias. We acknowledge that.
I feel like you'd have even more benefits if you could get it there than if you're doing it on the North Shore or something. There'd be even more benefits in Surrey Hills or somewhere.
Some things can be done as quality improvement projects, where you then don't need consent, but they would need to be done sort of at a hospital level or at a community health type level. And I think what Deborah said before is finding the motivators for the person is the key. I'd like to thank all the panellists for a great session, and thanks everyone for listening, and we'll see you after lunch.